Welcome to The Patient Physician, a space for doctors to explore their physical, mental, and financial wellness. Your peers and industry leaders will destigmatize institutional perceptions while redefining success, money, and personal care. Get ready to pull back the curtain, because here, you are both patient and physician.
Welcome to the Patient Physician Podcast, live from the 2025 ACGME Conference in Nashville, Tennessee. I'm Paul Smith, your host, joined today with my co-host, Chris Fulbright, and our special guest and friend, Dr. Michele Blackwell. Welcome to the show.
Thank you so much. I'm excited.
Thanks for joining us today. We've known each other for more than a decade now, and being friends, and really we feel like family now. But I would say that Chris and I have been looking forward to visiting with you and sharing your story because of just all the different things that you've been through in your career. And as we were talking about prior to starting the show, just how much people go throughout their career, and they don't think that it's a great story. They don't think they have a story, and yet it really is. And we believe that what you have to share and what you've been through and how you're continuing to forge through, you're not done yet.
Right. And I think that when you're in the throes of evolving as a physician and your practice, you don't realize you have a story.
Yeah.
You're winging it and you're just trying to survive and create the best practice you can while balancing family and other aspects of your life. And so I think that since we talked before the podcast, I thought back, I kind of do have a story, and it can help people, I think, to share that.
Yeah. It reminds me of this Steve Jobs quote that I talk to a lot of people about, where he says, you can't connect dots looking forward. You can only connect those dots looking back.
That makes sense.
And so what we do is we make the next wise decision, right? Mm-hmm. So when you're going through your career, you're like, okay, where am I interested? How do I go? I'm going to start over here, but then you pivot, which we have seen now after interviewing dozens of physicians. That decision, that courage point, is one of the things that Paula and I are so excited to talk to you about, because not just starting your own practice and being successful there and all the things we want to talk about, but also changing where your focus is.
Right.
And continuing to study that and become known in a new arena. So we're super excited. Yeah. Thanks for flying to Nashville for our
and
on-site.
this freezing cold weather.
Yeah. And negative 400 degrees in Nashville, Tennessee for some reason. So
I know. And if my voice starts to jitter, it's because it's freezing in here.
Yeah.
I need gloves.
And I flew here just to see you guys, by the way.
That's perfect.
Thank you
That's
so much.
perfect.
Thank you so much.
Yeah.
Don't worry about all the spa treatment she has scheduled for later.
That's exactly right.
Well, let's just start from the beginning. Can you tell us sort of your entry point into medicine? You started in academics, and then you're in private practice now, but start with the academics. I mean, we're here at ACGME. This is where it all starts. Yep. They're talking about the evolution of medicine and where it goes from here. But you really are that evolution, that tip of the sword right now as you're out in private practice, and we'll get there. But start from the beginning and tell us a little bit about how you got to where you are now.
Yeah, and I think saying I was in academics is a little inaccurate, although I worked at an academic institution. I was 100% clinical. When I finished my residency, they were just starting up a 100% clinical track private practice for the folks in and around Galveston to serve the community that needed their health care through UTMB. And I'm OB-GYN trained, board certified in OB-GYN. So I started off there and became very quickly very busy doing general OB-GYN. I had a passion for the surgical aspect of it, but when you're captive to an academic institution, you have to do what they want you to do. And the primary driver is obstetrics. So very, very busy obstetric practice, surgical practice, all of the above, working way too much. But you pay your dues. It's the specialty I signed up for. And I'm not saying I didn't enjoy it, but looking back, I'm like, how did I survive that? I mean, it's hard, very, very difficult. And as I was stating earlier before the podcast, I'd been doing this for 10 years and I hadn't learned anything new. And I was kind of itching to learn something new. Right about that time, Hurricane Ike hit the island. And so the university went through some pretty dramatic changes, political, financial, blah, 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 blah. And I had been unhappy there for a while and working too much. I wasn't happy with it. And I wasn't happy with the fact that I couldn't provide the care that I wanted to provide.
Yeah.
So after the hurricane, when things got restructured, they had shifted our practice off the island mainly anyway. And a friend of mine at the time connected me with an ex-resident colleague of mine that I went through residency who had been in private practice in the Clear Lake area for the last 10 years and was looking for someone to office share, which meant me being in a solo practice, the other doctors in the group being in a solo practice and sharing the overhead.
Yeah.
And I'm desperate to get out. So I, looked at the financial numbers and all of that. And it was a little scary leaving a set income and not knowing where I was headed. I was very fortunate that 90% of my patients followed me because they knew where I was. And the university was very forthcoming in giving my patients that information, which is not the usual because they're university patients. But they knew that my patients would seek me out anyway. So they were very generous with that information with my patients, and I'm very grateful to that. So I probably didn't take home a paycheck for 4 or 5 months, and I was working every third or fourth night call, so it was just as hard. Fortunately, my husband makes an income, so my lifestyle was cramped a little bit, but I survived. And then after that, being with that particular group of physicians, the overhead was just exorbitant. The things they were wasting money on, like thousands of dollars on a July 4th picnic. I mean, come on. Ridiculous. So
I don't know. I didn't go to that picnic, so it could have been awesome.
Yeah.
I don't know if you didn't get any patients out of it.
It's ridiculous.
Maybe it's not worth it.
It was not worth it. But just a lot of spending, too many employees. When you have so many women in one place, you get a lot of personality conflicts. So another friend of mine introduced me to the physician that I ultimately ended up staying with. Same thing, office sharing agreement. So I was in private practice. She was in private practice. And we had an office manager and some staff. And that office manager to this day is still my office manager. And that was in 2011, I think.
Okay.
Yeah. And she runs a lean practice. So I was like, oh my gosh, this is all I have to pay each month for my overhead. So I started making money again, but still the OB was just driving me down, and I didn't have enough time with my family. And I made a decision after a couple of years, maybe I don't remember, I can't remember dates, but to stop doing OB. That physician, that was just the two of us that shared the office. Very sad circumstances, went out on permanent medical disability after I started there about 6 months. So I had amassed all of her patients, and it was a very, very hectic time. So I stopped doing OB, and I was kind of bored. I love my lifestyle, but I was kind of bored with the medicine part of just plain old gynecology. And that physician who went out had been in the bioidentical hormone realm. And when she left, her patients were like, what do I do? I'm like, I don't know anything about that. So we were sending them out. And then Amy, my office manager, she says, why don't you go learn that? And I'm like, yeah, I think I'm going to go learn that. And that's kind of how this evolution started. And so it took me a couple of years because I had to work as well as go to the conferences to get board certified by the American Academy of Anti-Aging and Regenerative Medicine. Got that right.
That's right. That is a mouthful.
We can wrap it up now.
Yeah,
it's not going to get better.
So that's how I learned the ins and outs of bioidenticals. Then seeing how it changed people's lives was more rewarding to me than delivering babies. I just, when people say you saved my life, you saved my marriage, I'm myself again, that is just very, very powerful. And it has been a challenge fighting the mainstream medicine with bioidentical hormones. And I think a lot of that's political, financial, pharma driven, because there are plenty and a plethora of studies that show the safety and efficacy of bioidentical hormones. And here I am.
And so that was really more of just a happenstance that you ended up going into this subspecialty.
Can we take a step back, too? Because I forgot one other thing.
Sure.
Absolutely.
Yeah.
When I left UTMB, this is a big pivotal moment. I don't know why it didn't pop in my head because it's again, it's what I do. But learning robotic surgery. when I said I was at UTMB for 10 years and hadn't learned anything new, well, they were thinking about getting a robot, but it was only for the cancer doctors. So when I left UTMB, my partner at the time asked me to come to one of the hospital staff meetings, and that's where they were just introducing it to the mainstream OB-GYNs, not just cancer and urology. And I remember the rep say, "Hey, you want to learn how to do the robot?" And I said, "Yep, sign me up." And I never looked back. And that was in 2010. And I'm an exclusively robotic surgeon. I don't open women anymore for their hysterectomies. And that was a big stepping stone for me because I was hungry to learn something new. So that's
and somewhere along the lines, you also ended up subspecializing in helping astronauts.
Yeah, I think that was a connection through my husband's development of the space medicine program and his relationship with Richard Jennings, who was the head physician for the female astronauts. They're easy. They're so healthy. So, and he retired and I'm like, yeah, sure, I'll do it. And so, yes, they come to me for their just routine stuff. But again, there's such an amazing group of women. They come from all different backgrounds. They're all just kind of wild women because they're pioneering that stuff. But what I do for them is simple, easy stuff.
You know, the other thing that didn't get really covered and is not something that should be overlooked is the fact that you were raising a family. You have 3 kids, and your husband, you keep referring, is also a physician. And so if you can take a few minutes and just speak to that, because I know there's a lot of people out there with families, and or maybe they're in training and thinking about starting a family, because that's a big decision. Do I wait? Do I start to have a family now during training? That's difficult. I still don't understand how a lot of people navigate having families. It's enough to have children all on its own, but then still going through training or having a dual physician household.
Well, I don't know how people have kids in training either. Personally, I waited until I finished my residency and had my first child about a month after that. I was fortunate that the timing worked out. You know, when you start trying to have a family, you never know the timing. I don't know how ladies do it and men, but I think it's a little more friendly now than it was 30 years ago, because I know residents that were mistreated because they got pregnant at the time. And Dr. Blackwell, my husband, is very passionate about protecting that, because fertility is fleeting. If you want to have a baby, you go have a baby and you figure out how to make it work. We had a live-in help, which, because I was, on call all the time, was the best option for us. And I still missed out on a lot, but I tried my best to spend as much time as I could with my kiddos, and they all turned out okay.
I would say,
but none of them are going.
I would think they're being okay. Yeah.
For those listening, they did more than okay. So let's just set that record.
But none of my kids are going into OB-GYN.
So they took the warning shot, right? You're taking care of your family. You go from being in an academic setting to in a private practice. That was a struggle. And then now you're leading into a subspecialty of medicine, which gave you that educational insight that you were looking for. So you're able to feed that yearning and thirst for more knowledge. So where did that lead you to that you're at today with your practice?
So I still don't deliver babies. I did stop doing that 12-ish, 13 years ago. And that was a game changer for my mental health, my physical health. I was a hot mess back then. And my family, it was amazing. And so I'm trying to figure, I can't remember exactly how we integrated in this hormone wellness practice, because it's a cash-based, non-insurance practice, but I still have my insurance-based primary gynecology surgical practice. Insurance doesn't cover anything that helps people be healthy. They cover when you get sick, they cover that kind of things. And it is frustrating, but I don't know if in the next decade, if that's ever going to change. It's just not. So I guess people use that term concierge a lot. I don't like it, but it's kind of what it is. And I think they use that when you pay cash for your doctor's care.
The subscription model, the monthly types of,
Yes, and
access time type thing,
And that's
which is going to be more focused on preventative and actually whole
things that aren't covered anyway. And so I've set my practice up. It's evolved over the last 10 years I would say it's probably 60-40, maybe 70-30, with the primary part being the hormone medicine part of it. And I take very good care of my patients. They're always being monitored. You can go to any med spa on any street corner and get hormone pellets. They don't know what they're doing. I'm sorry, but especially with women, our hormones are complicated, and there's so many other factors besides just, okay, here's your weight, here's your levels, here's your dose, and that's it. And they don't know how to troubleshoot problems. And I've learned over the years, it's not easy, but you learn through patient experience how to troubleshoot problems that you have. The other thing, I think it was about 7 or 8 years ago when I started doing the pellet hormone therapy, my ladies were like, you got to help my husband. I'm a gynecologist. I'm not going to help your husband. He needs to go get his testosterone somewhere else. And I mean, people just kept asking and asking. And I'm like, I reached out to a colleague of mine who I met through the A4M institution. And I said, can you teach me how to take care of men? And he said, oh, piece of cake. So I started treating men with pellet therapy. And
Did you hear that? We're a piece of cake, and women are complicated.
Well, I don't know about y'all.
I didn't hear that, Paul. That's what you heard.
I don't know.
I think we hear what we want to hear.
I've heard I'm high maintenance.
Yes.
I don't know.
I was going to say, Paul, I don't think that you would be easy.
I make it complicated.
One of the things, Dr. Blackwell, I hear you say, and again, as we've spent time with physicians, is your ability to continue to grow, but to pivot.
Yes.
And when I have met with either business owners, entrepreneurs, right, like yourself, but also physicians, is we're looking for a clear path forward. And once we get on that path, it's almost like if we've changed and we made a bad decision somewhere in the past. Whereas you've taken this and you continue to pivot. And you're like, okay, I'm going to go here. Well, let me try this partnership. Okay, well, let me try over here. Well, let me learn this whole new thing. Well, my business partner changed. Any one of those could have been a hurdle for you to go, too much work. I have kids. Right. I'm going to go back to where it was safe.
Yeah.
All the lights aren't green yet.
Right.
But I feel like I'm on the right track. Could be the hormone replacement. It could be service to women. Stopping a major part of your practice was another huge decision.
Yeah, that was big.
If we go back to the patient-physician, we think of physicians throwing their earbuds in, maybe going for a walk. If you're down in Galveston, you're on the walking along the beach. Or they're driving in early in the morning. Yeah. They're trying to figure out, and your voice of saying, it's okay to pivot.
Yeah.
It's okay. Hey, I want to learn something new.
Well, and here's, I'll use one example in my hormone practice. The A4M, where I got my first certification, or board certification. It's not an ACGME accredited, but it's a board certification. I think they're through the University of Florida. At the time, it was just creams, hormone creams. When you got on bioidentical hormones, that's what you prescribed. And that's what I went to learn, because I had all this group of patients that didn't want to drive to Houston to get their hormones that my previous partner had left behind. And so started doing that. And for the most part, things were going well. And it was like, but my patients were like, yeah, well, I still don't have energy. I still have to take naps. I don't have a libido, those kinds of things. And I'm like, well, your numbers look good. And the A4M is very conservative in their hormone replacement. And so I can't give you any more, kind of thing. And then so I was at an A4M meeting, and this was pre-COVID, probably about 7 years ago. And I was sitting next to this nurse practitioner, and there was a lecture on pellet therapy. And it was very captivating. And as a gynecologist, taking care of all the screw-ups that med spas were doing at the time, I'm like, who in their right mind would ever put a pellet? Who would get a pellet? I mean, they just didn't know what they were doing. And women would come in bleeding all the time. And I'm like, well, why are you on estrogen when you're on birth control pills? Well, my estrogen levels were low. That's because they are low when you're on birth control pills. You don't, it was so frustrating. And I thought, I'll never do that. Well, when I learned through proper channels that how life-changing they can be, I shifted to doing that. Tried it myself beforehand, because I'm like, I'm not going to do anything to my patients that I wouldn't do to myself. Right. And that's kind of how that evolved. And I really don't prescribe creams anymore. I have 5 patients that I kept through the years that were very compliant with their testing. And but I'm thinking about going back and offering creams again to people who want them, because they're scared to try the pellets, and their friends have, as a option for these people that want something maybe less expensive, but could potentially have a very good experience with. So I'm working now on trying to figure out how to integrate that into my practice. So there's a couple of little pivots around the hormone industry, hormone medicine. And I don't do full functional medicine. I'm just hormone medicine. But I would like to, and I do prescribe regular hormones in my gynecology clinic. So that's a totally separate thing. Yeah. That's an example of a couple of pivots in the last probably 7 years. Yeah.
Taking that decision and then still making it better, right? And continuing to learn what is there. And then I love the coming back and revisiting things, right? Where it's like, hey, maybe it's not the right choice for now, and then learning more about it and then coming back. And I heard you talk sometimes about, I'm just going to say med spa because that's what you said. Yeah. Can you share some of the downsides?
So there are several companies, and I'm not going to use names, but there are several companies that help. And this is one good thing about it, is they help bring hormones more to the masses, the bioidentical hormones. And some people do fine with that system, but some people don't do fine with that system. And it's typically a 2 or 3 day course, and you can do hormones. You're a hormone expert. And it's not that simple for most people. And, I do have a few providers in my area that are at med spas that I trust. If a patient can't afford me, because I'm a lot more expensive than a med spa, but you also get more service with me.
Yeah.
And I do refer some people out because I don't want these ladies to stop because they can't afford it. And so it is a more affordable option for them. But in general, you pay every time you go get a pellet. They don't cover your labs, and it's algorithm based. And people ask me, well, what's the difference between you and that company or this company? There's a couple of them now. And I said, I use my brain because I don't follow any guidelines. I just have learned over the years. When you first start out, you have some guidelines on dosing and things like that, but you learn through continuing education and patient experience how to safely do it and manage side effects.
Well, and you must be doing a good job because you have patients coming to see you from what I understand all over the world.
Internationally, people are coming in.
I do.
And those of us in Texas means anywhere outside of Texas. International exposures, anyway. Yeah.
International doesn't mean off the island,
That's
right?
right.
No.
Well,
oh yeah. No, I have a nice cohort of patients that come from elsewhere. I have a couple patients that have moved, out of state, and one that moved into Mexico, and they come back to see me.
On your website, it goes through a thing on your philosophy. There's a couple that just to touch on as we go through it, but you talk about the patients that are premenopausal, menopausal years, and treating thyroid disorders in women of all ages. Can you go deeper there? I know that as we've all gotten older, our friend groups, the people around us are going through those different stages, and can you speak to that?
Perimenopause. I was listening to this podcast the other day. It's called The No Man's Land. And I'm like, that is a great explanation of it because, and I tell my patients, I went through the same thing. Fortunately, I survived and didn't end up totally crazy. But it's the perimenopause, and it can last 10 years for some people. It can last 6 months. I mean, some people don't even experience, but a majority of women, it's the roughest time in your life, and it's going to be in your 40s. And whether you have periods or not, your progesterone drops out, your estrogen goes all over the place. One day it can be 300, the next day it can be 0. It's just all over the place. And your testosterone ends up dropping out, and it is very tough to navigate. So I tell my patients the best thing we can do is mitigate the symptoms. Weight gain, poor sleep, irritability, moodiness, fatigue, and depression, anxiety. A huge cohort of women get put on antidepressants in their perimenopause or early menopause years when a lot of those are from hormone deficiencies.
Yeah.
And that's made a big impact on a lot of my patients too.
So do you see in that situation where if you can get a hold and help them through the hormone therapy, that maybe they get off of the antidepressants or stop using
absolutely.
Okay.
Not everybody gets off of it, but reduction in dose, especially with anxiety.
Yeah.
But I do have some patients that absolutely can get off their antidepressants, especially if it's kind of like you go through this midlife crisis, so to speak, when there's nothing really that triggers it, just everything. It feels like your whole world is going to implode. you get on an antidepressant to get yourself just to survive. And then more women are educating themselves and understanding maybe it's my hormones.
Yeah.
And they go to their doctor and they check their hormones and everything's fine. And normal is not optimal. And that's a very good saying I heard at a conference just a couple weeks ago. I can't tell you the number of times that women come to me with their labs and their gynecologist has told them, oh, everything's fine. No, you're not fine. You're falling apart.
Yeah.
Or, it's just part of getting old, honey. Suck it up, buttercup. And that just floors me in this day and age that's being said when we have so many options, even traditional hormone replacement therapy. And if you don't know about it, say, I don't really know how to interpret these labs. You need to go see a specialist.
All right.
So,
or if you're seeing a physician who maybe they haven't put the time in that you have to understand how the hormones impact these major life events.
Yeah.
Goodness gracious. Or they go and they, I guess we can say Google without having to pay them, search engine, right? And they put it in there and go, I feel all of these negative things, and it spits out, well, you're depressed or something, right?
Of course, because you are.
That's right. And so being able to prescribe and to then work with them on a close basis to help them through that season also tells them that they're okay.
Yeah.
Right? If not,
right. It validates their symptoms.
Yes.
Oh, my gosh. I've had so many ladies cry in my office saying, so I'm not crazy.
Paul?
No. I'm sorry, Paul. I violated HIPAA there.
Why did I know that was coming? I was like, please don't say that I was in her office crying.
I violated HIPAA.
Who is
Paul.
that woman crying in your office? Oh, that's actually Paul.
It's all the little language at the end of the podcast will be in there for you. It's a
all
HIPAA
this
release.
hormone therapy is for me. I'm in. Where do I sign up?
We had to fly your doctor to Nashville.
I know, exactly.
But, I get thank you cards from husbands that I don't treat. Thank you for giving me my wife back. And women that, I mentioned this earlier, this saved my marriage. And it's not just all about the libido issues. It's about your interactions with other people. When you can't think past your brain because your hormones, it's very powerful.
Yeah.
Yeah. And I'm saddened by ladies who go through menopause and they suffer maybe mildly or moderately. And they don't seek out hormone replacement therapy, just regular traditional hormone replacement therapy. Those women are doing a disservice to themselves because hormones reduce cardiovascular disease, osteoporosis. They help joint pains. They help sleep. Overall, hormone replacement therapy, I believe every woman should be on it. Now, there's an exclusionary if you have active breast cancer that you can't be on hormone replacement therapy, but vaginal dryness,
I knew that was going to get worked in. We had another podcast about that.
You can edit that out if you want.
No.
Our last podcast, Dr. Freeman talked. She is concierge in Austin, and she stressed the same thing. Right?
It just it amazes me that many women are I can't have sex anymore, and my husband's very understanding. I'm like, but don't you want to? It's like they accept that that's just the way it is, and. It's never too late to start hormones. I mean, I start 70-year-old ladies on hormones sometimes because they want a better quality of life.
Mm-hmm. Yeah.
And there's no harm in it.
So we've talked about hormone replacement.
Yes.
Obviously, the time you spent. Obviously, on your website, but also you, knowing you well as we do. Can you talk about nutrition and fitness and health a little bit?
How much time do we have?
Yeah, how that ties into women.
What makes you think she knows about fitness? I don't know. If anybody gets a second to look her up, I mean, that's another amazing journey that we're going to get to.
Yeah. I'm just getting started with that one.
Yeah.
But
how fun. We'll get to it.
Yes.
Another transition.
I know.
Another transition for her. Yeah.
But again, in my perimenopausal years, I could never have done a bodybuilding show. But, you get over that hump and you get your life sorted out and you can do things you want to do. You've always wanted to do. So I really, really try to counsel my patients, especially because we get that menopausal belly fat. And a lot of women don't understand the importance of strength training. They're like, oh, yeah, I get on the elliptical 5 days a week. I'm like, that's not doing your body any good. And regardless of whether you use hormone replacement therapy or not, it is so important for strength training, a minimum of twice a week, full body, upper body, lower body. Because as we get old, I don't know about y'all, I don't want to be old and not be able to get out of my chair.
Yeah.
And frailty is a big problem. our generation of women that are in our late 40s, early 50s, we grew up being cardio bunnies, and it's really hard sometimes to change people's philosophy with that. But when they do, to see their transformation, not bodybuilding transformation, but the way they feel and their body shape and their body composition, they feel better about it. One of the other things I have noticed in midlife ladies is, there's a big trend, and I fell into this, CrossFit, Orange Theory, 45, whatever that thing is called, where it's
F45.
high intensity for an hour. That is not good for ladies going through menopause. If you love it and that's the only thing you'll do, great. But it's not going to help you lose weight. It's not going to help build a lot of muscle because you're limited in how much weight you can pick up. I encourage people, if they have the means, to hire trainers so that they can learn how to train their body parts safely, especially if they've never been in the gym. And you know what? Just plain old walking. Walking is the best cardio you can do. But if you're a runner and you love to run, go ahead and run. Just add the strength training in. So that's so paramount to everything. And getting enough protein in, not overeating sweets. Alcohol is a big problem with midlife people. And that's just an evolution that people have to come to on their own.
I'm going to ask, what's the resistance, no pun intended, on the weight training? But it feels like, from my low level of understanding, I don't know why you got to give me the hassle.
That was funny.
I think it's great. I think it's good.
But I think
that's Paul humor.
Anytime
that is
I
Paul
know,
humor
I
right
know
there.
it's dad humor through and through. I'm sorry. My girls still love me, I think. Anyway, so my low-level understanding, or at least I feel like I've always heard women say, I don't want to do a lot of weightlifting because I don't want to get all big and bulky. I think that's the perception that's immediately going to happen.
Their mind automatically goes to bodybuilder,
and
like
you're
bulk,
turn into Darla.
bulk size.
If y'all knew how hard it is for women to gain muscle, if I can put on 2 pounds of muscle in a few months, I'm probably a poor example because I'm already resistance trained, but there's no way a woman can get that big.
Yeah.
So then what is the resistance
performance
there?
enhancing.
Is it either just the misunderstanding that I should be doing this, or the fear of, like, I don't want to be big and bulky and have a certain appearance?
I don't hear that quite as much. Time. I think there's fears of going into gyms.
Yeah.
Thinking it's intimidating. But I was listening to this other podcast the other day, and he's like, trust me, if you go in there, a bodybuilding gym, and you see all these meatheads in there, they ain't paying attention to you. They're looking at themselves.
There's a reason there's mirrors all the way across the walls. Yeah.
And they're there to help. If you have a question and you go up and ask somebody, they're going to help you.
Yep.
And it's true. It is true. I think time is a big factor. And hiring a personal trainer costs a lot of money for most places, but you can do anything on YouTube, okay? That you can get a YouTube video for anything. You can do, if you don't do any strength training right now, start with your body weight. Squats, push-ups. I don't know. You can get a gallon of milk and do kettlebell swings. I don't know. I've never done that before.
With the lid on. Got to make sure the lid's on.
That'll look a little...
Or you can go to Academy and get some 5-pound dumbbells and or resistance bands. You can, off Amazon, you can get resistance bands all the way from like 2 pounds to 50 pounds. And Google full body resistance band workout. That's so cheap and so easy. And if you have little kids at home, or you don't have time, or you don't have the money for a gym membership, easy.
God, you could do that on the road too. Take it with you.
That's what I do when I travel. Well, when I travel to places I know won't have a gym, I take my resistance bands.
How about like nutrition? As someone who's focused on building muscle, have you tweaked, or do you coach your patients on tweaking like the higher protein? Or, there's a lot of fad diets out there. I don't even call them fad, just nutrition, weight eats. What is your thoughts around that? And then do they change during these transitional phases?
Everybody's body is different, and what works for you doesn't work for you, might not work for me. It might work,
Sure.
So my general guideline is a minimum of 0.8 grams of protein per pound of body weight. That's too hard to do the math. So if you just say 1, now if you're 280 pounds, that's not what we're talking about, because half of your mass is fat. So maybe half of that. But in general, for a mildly overweight person, you can do a gram per pound of body weight, and then fill in the rest primarily with vegetables and healthy complex carbohydrates. But as far as calorie goals, ladies get into this, oh, I'm eating 1,200 calories. Well, you need to eat more than that. Nobody can subsist on 1,200 calories. But it's diet culture.
Mm-hmm.
Diet culture. And especially with all of the new GLP-1s, people are not eating enough protein on those. I really stress the importance of, even more important, with the strength training and the protein. And it's hard when you don't want to eat anything. Who wants to eat a piece of meat? That's
Right.
kind of...
Do you have a professional opinion about those and the
I think
popularity?
they're amazing. Yes.
Yeah.
The GLP ones, yes. The Ozempic, Mounjaro, and compounded versions, contrary to what the FDA says. Now, compounded versions from a reputable compounded pharmacy that you get from a physician are very safe and very effective. If you can go online and get a vial of tirzepatide for $40, I would be very leery of that, because there is a reason why it's that cheap. It is expensive to make. The raw products are to make. It'd be better if everybody could get it through their insurance, but that's a whole nother topic.
Yeah.
I think they've changed lives. The data is there as far as the health benefits you get from that. Not even people who don't need to lose weight can take microdose of those drugs and reap benefits from that. I've had people tell me all their joint pains go away because of the anti-inflammatory effects. Their moods elevate. Game changer. In my career as a physician, I don't think I'll ever see anything that's better for people's health than this.
With all this evidence and the patient satisfaction and lives that you're changing, think it's going to pick up, or there'll be more uptake to this type of therapy within the world of medicine, or is there going to be continued resistance? And how do you help forge that path to help it grow?
I think more women are empowering themselves. They come in and they have read, they have listened to informative podcasts. They come in wanting that stuff. And that, I think, is going to be a driving force. It's still all political, financial driven as far as whether mainstream medicine is going to adapt this. I know that OB-GYN residencies, they don't learn about hormone replacement therapy. Not the way they should, because I see young doctors prescribing early menopausal ladies low-dose birth control pills for their symptoms, and they help their symptoms, but why would you do that when you have a safer alternative? Or drugs like gabapentin or an antidepressant for their hot flashes and night sweats. Why would you do that when you get so much benefits from plain old estradiol and progesterone? I don't know. It's very frustrating. It's very frustrating. And the sad thing is in my community, I have to search out primary care doctors that aren't going to tell my patients they're doing themselves harm by taking hormone replacement therapy. So I have a network of people that I refer to, because primary medical doctors or primary OB-GYNs, I tell them they're not going to like you being on this. And I was in that boat. I was that person.
Yeah.
But my approach at the time was, oh, well, that's kind of cool. I don't know anything about it. You just let your doctor take care of you, versus people that say, oh, you're going to give yourself cancer, or, oh, you're turning yourself into a man. Why do you say things like that? Stay in your lane. If you don't know something about it, don't talk about it.
Or do what you did and start learning more
or
about
learn
it.
about it. Right.
Yeah,
Well,
hey,
all these patients are coming in on this stuff. Maybe I ought to do a little reading.
Yeah.
Of course, you do a Google search and you see everything negative.
Yeah.
So.
Yeah, the first 5 say one thing, the next 5 will say not to do the first 5.
Right.
And so finding the appropriate sources is important, right?
And,
on any
and
of this.
Social media influencers are not the place to find your medical information. TikTok. Sorry, Paul.
I don't even have a TikTok account
Anymore.
after today.
Paul can be read at Paul Smith. Yeah.
And that's right. Don't find my handle or whatever. What is it? I have love handles. I don't know about that. So if there's a young physician out there that is at the same place where you were, but is buying into what you're saying and has the same type of, where would you say that they should go? How do they get started on this path? Because there is room for growth, obviously.
Yeah.
If your calendar is filled up, that means that there's still more work to be done. There's more patients to be seen. How do they, I don't want to offer to put you out there to talk to these people or meet with them.
My training. How do you get in touch with other physicians that do this? I don't know, that's challenging. I went through the A4M. I'm not going to say that whole big long word jumble, but if you just Google A4M, they're kind of the leaders in the industry. You have to go through and learn everything, the cardiology, the oncology. It's not just hormones to get your board certification with that. But I enjoyed learning that because, it helped me. Some patients are very, like, their cardiologists don't talk to them about certain nutraceuticals that can help with their issues or whatever. I enjoy learning about it just to know about it. Do I use all that stuff clinically? No, but it was interesting. They do an oral board exam. They do a written board exam. So it's a real thing. You're not going to go to a weekend course and think you know how to treat hormones. They also do a lot more functional medicine. And if you have that route, there's also, I think it's called the IFM, International Functional Medicine, something like that. I don't know anything about that, but I know that's an entity where you can learn things like that. I just did a hormone course through WorldLink Medical. Very different, interesting perspective. But again, I still want the knowledge to know,
Sure,
to revamp my brain every once in a while.
we've talked about your propensity to pivot and grow.
Yeah.
Where do you see this industry specialty going in the next 5 years?
That's an interesting question. For me, I want to expand my services to help more people. And how do I do that when my schedule's already full? I don't know yet. As you know, my kids I have a new grandbaby, and I may not want to work quite as much. Maybe I'll offer more online services, virtual type services, which a lot of hormone doctors do. It's out there. You just have to do a Google search, and in your area where you live, it is out there. And you got to look at the credentials and the training of the people who are prescribing hormones and how they manage, issues. Patients have access, maybe not in their hometown, but virtually. And that's one of the reasons I kind of wanted to circle back into hormone creams and testosterone injections and things like that, because I can reach more people.
Yeah.
And if I sometime want to cut down, I can do it virtually.
Yeah.
But I don't know the answer to that question.
Yeah. Look, we know that you're flexible enough that you're going to go in the right direction. Yeah. Joe, who's the producer, who's in Nashville sitting beside us, which is wonderful. We don't
Lovely
see it.
Joe.
So one of the things Joe brought up yesterday, is I've seen the women in my family, as they've gotten older, struggle with their muscle and with standing up and the flexibility, and you're a focus on health and protein intake. And so I just think it's so wonderful that you're here to share your wisdom and experience and knowledge.
Okay, so I'm 48.
Okay. Oh, that was a rough year for me.
Well, I'm not experiencing a lot of the things that you're talking about, but I do notice, like, the muscle mass thing was something that was a big deal for me. And I drink a lot of coffee, and I was noticing my face.
You're dried out?
Yes. I've just been searching for what are the right things to drink and to do so that I am naturally taking care of myself.
Yeah.
Because I don't want to do plastic surgery. I don't want to do fillers or any of that stuff. So how do we stay hydrated and keep ourselves?
That's challenging. Obviously, water as your primary source. But one of the things I think you ought to do is get your testosterone levels checked, because most women in their 40s have low testosterone. And just because your lab value may not be flagged red doesn't mean you're not low. You have a symptom complex. Your energy levels, your skin turgor, your muscle, difficulty developing muscle mass. And when we say muscle mass, we aren't talking physique competitors. We're just talking about building muscles so you can be strong and healthy and agile when you get old. That would do you a lot of good. And testosterone replacement is very safe in women. In fact, when we're in our reproductive years, if you convert the units of testosterone to the units of estradiol, there's a great graph out there. We have more biologically active testosterone than we do estrogen in our reproductive years. It's just reported in different units. So it looks like, our testosterones are here and our estrogens are really high. There's no guidelines for what defines low T in women. It's a symptom complex. And everybody has it at some point. And it's good that you're not experiencing all the craziness yet. Hopefully you won't. But if you can get on something like that, and that's natural. Hormones are natural. I mean, you can't debate that. That's a natural thing. Your transition into menopause will be it's so much easier.
Okay.
Yeah.
That's promising. Yes, because I don't feel those things, but I'm like, I am drinking a ton of coffee, so I'm clearly needing to keep myself
The energy
up.
levels.
Yes.
Yeah. How's your sleep?
Well, it's normally good, but I was just telling the guys, I was like, I could not sleep last night.
Yeah.
And I was like,
well, you're in
did
a
I?
hotel, so.
Yeah. Typically I sleep pretty well,
Good.
but I notice like I feel weaker.
Yes.
I've been doing more push-ups.
Get you testosterone and go to the gym and get a trainer.
All right. Thank
So
you.
we've talked a lot about the services and hormone therapy for women, but you did move into treating men, and I'm just kind of curious how much that's grown in the practice. What percentage? I'm sure it's mostly women, but
It's mostly women. I can't give you numbers on that. I have a lot of couples. I have some other men that just find me on Google. Believe it or not, psychiatrists send me a lot of patients that, they're men and women are they're at go to get your hormones checked kind of thing. A lot of times when I have men come on their own, their wives end up being patients too. So I
Same
really,
way it worked with the wives, right?
Yes.
They get that fixed, and then,
Yes.
hey, can you work with my husband?
Yeah.
And, yeah, great.
Yeah, for sure. I don't know off the top of my head what percentage of men I have. Because they kind of cycle, because male pellets, we do them about every 4 months. And so some weeks I'm got 10 of them coming in, and then some weeks I have one. So it's just hard. It's hard for me to put a number on that.
before I ask the last question, I just want to say thank you. I know that you stay super busy, and I appreciate you sitting down with us today. I think that the knowledge and the wisdom that you shared will ripple more than you think. The name of the show is The Patient Physician. And so as the last question we always like to ask, what does that mean to you? What does the patient physician, when you hear that, mean to you?
First of all, be patient with yourself. Give yourself some grace, because the business of medicine it's changing all over the place. And what might be true today in the business of medicine 5 years from now won't be. Love your job and be patient with your evolution. Yeah. But again, when you're in the throes of it, you don't know you're evolving.
That's right.
But yeah, just be patient with yourself.
Yeah. And there's just it sounds like the consistency there is things are going to change.
Oh yeah, for sure. And if you're the kind of physician that wants to get a paycheck and you don't mind being told what to do and having to meet, standards as far as the RVUs that most employers make physicians target at, then by all means do that. And I do have a lot of friends in the OB-GYN industry that have gone to hospitalist positions because it's a more predictable lifestyle. But you have to figure out what works with you. Yeah, for sure.
Well, thank you so much for coming. We
You're
appreciate
welcome.
you flying in. The next time we go on a trip, we'll just have Dr. Blackwell fly in to see us again.
Right. We should choose something a little warmer next time.
Yeah, let's do that.
Something sunnier. What's wrong with the temperature here, Paul?
I don't know, but I need gloves. And I'm indoors.
That full-length mink jacket you're wearing, though, is a little off-putting. Yeah.
Well, why? Because it's maroon or...
Yeah, maroon. Maroon is the color of the week. All right, Dr. Blackwell, thank you so much.
Thank
we
you guys for
appreciate it.
having me. This was fun.
Awesome.
Thanks so
Sorry
much.
it took so long to get me on.
This conversation was brought to you by Physicians Resource Services, a firm supporting medical professionals to improve their financial situation and pursue their personal and professional goals. The Patient Physician is produced in Austin, Texas. Editing and sound design are in the hands of the PodConnects podcast network. Please email questions or show ideas to info@physiciansrs.com.